This is QD Clinic. Hi, I'm Jack Cush with Rheum Now. QD Clinic's brought to you by PSA All the Way, Rheum Now's campaign on psoriatic arthritis all throughout the month of April. Look for it. Not only are we going to bring back Tuesday Night Rheumatology every Tuesday night, 7 p.m. Eastern, 4 p.m. Pacific time. We're also bringing back a lot of guest blogs on PSA. Look for a weekly survey, our live vote survey, where you get to give your opinions about hot topics, hot issues, hot questions in psoriatic disease. Look for those appearing, I think, in your mailbox every week. Today we're going to talk about questions from you who attended Rheum Now Live 2022. These are questions on spondyloarthritis. So this is your spondyloarthritis questions. First question, do you ever use Remicade in patients with ulcerative colitis and polyarthritis? And the answer is, of course, yes. Remicade is approved for, one, the treatment of ulcerative colitis and Crohn's disease, both in adults and in pediatrics. The thing to remember about treatment of colitis with Infliximab is that the starting dose is 5 milligrams per kilogram and can go up to 10. The same dosing interval, 0 to 6, and then every 8 weeks. But as is always the case with IBD, you have to control the gut if you want to control peripheral arthritis. So if this person's having peripheral arthritis and either the gut or the peripheral arthritis is not controlled, you got to get control of the gut. So if Infliximab is not going to do it, you got to get other therapies, and there's a whole bunch of approved therapies, including recently high-dose JAK inhibitor therapy. So working with the gastroenterologist is probably the single best thing you can do to get control of the polyarthritis associated with ulcerative colitis. I have a few patients with ulcerative colitis and polyarthritis who failed everything. A lot of questions about ulcerative colitis. What to do? Well, again, the same thing. Work with the GI person. Think about newer therapies, which would include the JAK inhibitors, mainly tofacitinib at higher doses. And there's a protocol for starting patients with ulcerative colitis on a higher dose and then coming down to a normal dose, so as to avoid a lot of the risks we're worried about these days with high-dose JAK inhibition, mainly VTE and maybe cardiovascular events in high-risk individuals. I may not be remembering this right, but a few review courses ago, it was said it was okay to use methotrexate with NASH. Yes, you can use methotrexate with NASH. In fact, that's part of the new ACR guidelines. Patients with NASH and rheumatoid arthritis can acceptably receive methotrexate therapy if their LFTs are not wacko and sky high and worrisome, and their NASH is stable, and they have no other risk factors that would preclude the use of methotrexate in someone who has fatty liver. Do you have any data about hydroxychloroquine in pregnancy? Again, this is on spondyloarthritis, but I'll take it anyway. The answer is there's plenty of data about hydroxychloroquine in pregnancy. You get better control of the disease during pregnancy. There's less miscarriages. Maternal health is better. There's less problems with fetal loss from antiphospholipid antibody syndrome. I mean, it's the one drug you definitely should continue throughout pregnancy, no questions asked. I think there's overwhelming data about that. Any data about gluten and spondyloarthritis or psoriatic arthritis? There is data. It's kind of weak. What we do know about data for these disorders is that anti-inflammatory diets, there seems to be some evidence to suggest it might work. Anti-inflammatory diets could be called either Mediterranean diets or could be called no gluten, low carbohydrate diets. And in our practice, we've seen a ton of patients who've done incredibly well by going gluten-free with their psoriatic arthritis, with their psoriasis, and with their spondyloarthritis. Now, we have no controls, and no, this is not due to weight loss because of diet, okay? But well-done studies are kind of lacking here. There's a few studies that says that a low-gluten diet might be advantageous, but there's probably more that says it's not. Again, patients love to do dietary manipulation. Don't let that happen at the risk of getting worse and not taking a more effective agent. But there are some patients who may want to pursue that. And again, it works well in our hands because we give them like a 12-page handout on what a gluten-free, low-carbohydrate diet is. Don't take this, do take that. Really specific instructions. What's your experience with colitis and IL-17 inhibitors in SPA? And mine is like the literature. I think I have one PSA patient and one SPA patient who has, and actually this is fictional because if I say I have a patient, I have to report it as an adverse event. So let's just say I'm imagining a patient who's on an IL-17 inhibitor and develops bloody diarrhea and gets biopsied and gets shown to have colitis. The question is it due to the IL-17 inhibitor or is it due to occult inflammatory bowel disease? When I've encountered this, much to my surprise, it's been due to occult inflammatory bowel disease. Because if you stop the IL-17 inhibitor and the problem never goes away, well, then it was an occult IBD problem, or you magically caused disease that never went away with the IL-17 inhibitor. That's not generally the case. The risk of colitis with IL-17 inhibitors was like 1 or 2 in 1,000 without a background of spondylitis. It's like 7 per 1,000 patient years with spondylitis. Not surprising given what we know about spondylitis, terminal ileitis, all that data back in the 90s about treating occult regional enteritis or terminal ileitis with sulfasalazine. That's why they may have gotten better, but now we know the real story on that. Is upadacitinib approved for AS and AX-SPA at this time? The answer is no. Tofacitinib is. Watch any day now. This is, I'm recording this on the 29th of March. I'm going to guess within the next 2 weeks it will be. That's just my guess. Okay, but it's soon to be approved would be my suggestion. Watch Room Now for an update on that. How robust is the data about JAK inhibitors, either tofacitinib and UPA, in ankylosing spondylitis? Would you do this before a TNF inhibitor or an IL-17 inhibitor in AS patients who may not want to have injections? It's a question from John Goldman in Atlanta. Thanks, John. I think the data is really strong. It's really strong. The mavens in this area think this data is as good as any that they've seen with, the IL-17 trials, of which there are many, the Cush trials with ixekizumab and all the other trials with secukinumab. But the JAK data looks really good and really strong. And, I think it's going to boil down to a formulary issue rather than a preference issue. But, guidelines are going to ultimately say anything that's proven to work, it's going to slot into an algorithm based on how it was studied. All of these are going to be studied in people who either failed nothing or failed a TNF inhibitor, so they'll get that approval. So theoretically, they're all equipotent here, a TNF and IL-17, a JAK inhibitor. It might fall into whichever you prefer, or whether a patient will or will not take an injection or a pill. Do young female patients ever get enthesitis related to HLA-B27? Why do the criteria always just talk about young males? Usually it's over the age of, 7 or 9? And that's statistically where the numbers are. Older kids over the age of 7 up to age 16 make up the biggest group of that juvenile, either enthesitis-related arthritis group or the juvenile, we call juvenile spondylitis. But there are plenty of young women in this group as well. I've had several. They presented with isolated, severe, disabling Achilles tendonitis or other forms of enthesopathy that prevented them from participating in high school and collegiate sports. Put them on, back then, a long time ago, a TNF inhibitor. Now, more recently, you have more options, including IL-17 inhibitors that would work very, very well here. Anyway, that's it for questions from Room Now Live. We got one more tomorrow. Tune in. and watch for our campaign on PSA All the Way.